think back to the last session's slides about threats to internal validity, that sort of history and maturation and so forth, we worry about all of those things, and it's particularly concerning if you have something that's relatively rare, so you need to have a larger sample size, which means that if you can't go out geographically, you need to add sample size by adding years, then we worry about things like that, that things have changed over time. You know, again, not a fatal flaw if you know about imaging techniques or if you know about the changes that you can control for those types of things. It's when we don't know what's happening, then it becomes a little bit more worrisome, and that could be what's explaining the differences that we see. Absolutely. Yeah.
And another issue with bias is that this is not, the whole clinical care guideline is being rethought, and so it's not only perhaps some other things will change, but it's also forced people to go through the literature with more of a fine-tooth comb than maybe they wouldn't have otherwise. So they might just change their practice based on like all the conversation and everything that's happened around changing the guideline.
Right, right.
And so, yeah, I think
so then the trick with that, right, is that so it's not just the bias that you bring up, which you can assume, you can probably make a pretty good guess about which direction it's in, but if you have people combing through the literature more and making clinical decisions around in a way that you might not be able to predict that the bias might go. So it may be that they're more likely to diagnose an abscess with a particular medication. You can sort of predict that's the direction it's going to go in, but when you have this type of situation, you don't necessarily know. It could bias it in the opposite direction. So again, not a fatal flaw, but understanding how you might think about that. So what might be, if you were really concerned about that and you still were thinking about doing the sort of retrospective and prospective combination of a study, what would be one way you could potentially address that issue? Yeah?
Mm-hmm. See if there are other things that have improved patient satisfaction, time to just, other things that may not be entirely dependent on the antibiotics.
Mm-hmm. Right. So, and again, these are not, mutually exclusive categories. So even thinking about framing this as a program evaluation, so then you're looking at some of what we call mediators. So, abscess might still be your sort of clinical outcome of interest, but the other things, clinical indicators that you mentioned, including length of stay, other things that are of importance like patient satisfaction, family caregiver satisfaction, and things like that. And so thinking about the program evaluation components and the process measures that might go into this may include not only thinking about interviewing families and patients, but also the physicians involved to get a better understanding of their sort of attitudes and behavior and knowledge around decision making might be incredibly beneficial. What's the drawback of that, though? It's part of it's retrospective, right? So you can't, right? So you may not be able to access that information, or you cannot in some situations. But assuming you had a group of physicians that it were possible to go back and sort of ask them and get all these process measures. What are we thinking about in terms of these types of other domains here? It's getting more expensive, it's getting longer, it's becoming much more involved study because it's not just the randomizing, or it's not just thinking about drug A versus drug B. Now we're thinking about designing surveys and validating surveys and so forth. But again, potentially a stronger study design where we're integrating different components. Sort of we're taking the strengths of each of these approaches and kind of melding them together and integrating them into a potentially stronger study design. But again, probably more expensive and more lengthy, for sure. Other comments or thoughts about? Yes?
The other thing I would say is that you also, if you go outside the parameters of a randomized controlled trial, the other thing you have to worry about is that you may not be able to assess your outcomes adequately, so you don't have the kind of safety monitoring and ability to kind of decide if you're having too many bad outcomes. Obviously you're going to monitor like your abscesses and so forth. And obviously, if you switch over and you have 17 within the first 3 months, you're clearly off to the wrong track. But if you get your sample size predicted ahead of time and you randomize and you have a rate and a time, then when you have bad outcomes, you can decide, is this a criteria for stopping? Is this something that is happening out of proportion in one arm versus the other arm? And you can kind of do that in a more systematic way. I think you might lose that if you just kind of compare things where you might have outcomes that you didn't anticipate and don't know exactly how to compensate for.
And it goes again to the research question about, I mean, in that situation where you're randomizing, you're trying to make, you're at equipoise, right? You're trying to make a decision about, is drug A better than drug B, in the sense that we will progress forward not knowing the answer to this and make a decision point if there are many adverse outcomes, as opposed to the sort of point in time where the decision is made to switch, and then we'll compare. So you're suggesting there's probably more control over adverse outcomes. Again, both are going to be obviously monitored by an IRB and so forth, but where the focus is very specifically on the adverse outcomes, there's the potential for, for it to be monitored, more closely, for sure. Other comments? So you'll have to let us know keep us updated about what you decide, how you decide to move ahead. So again, just in, kind of in summary about this, there's no perfect study design, right? I think we can even think about this if we, look at each of these. None is perfect. I mean, some certainly are more appropriate than others, but probably the best approach is to integrate parts of each so that you can have the best sort of handle on what your biases might be, and that balance between internal and external validity within the constraints of time and cost and so forth. And so, it's a very flexible sort of approach that needs to incorporate many aspects, and there's no one perfect study design. All right, so that was going to be my example about very low birth weight babies, but thank you for offering your example. That was very helpful. So what we're going to cover today are secondary data sets. And so the objectives for today are for you to become familiar with some major national secondary data sets in the United States, to compare the relative strengths and limitations of these databases, and to understand some of the ethical and administrative considerations for research using secondary data analysis. So just to orient you again, we show this every week about our little roadmap here, and we are going to be now here thinking about more specifically study designs and secondary data analysis. So last session we talked about quasi-experimental, survey, and program evaluations, and we finished up that a little bit today, obviously. And today we're really going to focus on secondary data analysis. And so just by definition, secondary data analysis is any reanalysis of data or information that has been previously collected by either another researcher or an organization, including the analysis of data sets collected from a variety of sources to create time series or area-based data sets. So what we're going to focus on today are health surveys, some nationally representative health surveys, and administrative databases. And these can either be cross-sectional, which is just a snapshot in time, or panel and trend data where groups are followed over time. So national survey, so these include things like the National Survey of Children's Health or pediatric hospital data. So I'll give you a couple of examples of each of those. So the overall strengths of doing a secondary data analysis usually are sample size. You're getting very, very large samples. I mean, the order of 40, 50, 60, 100,000, sometimes 1 million observations you'll see from some of the hospital discharge data. It's nationally representative. They measure many covariates that you wouldn't necessarily be able to access with a smaller database. Often databases can be linked so that you can follow people as they either move through programs or linked birth certificate and other administrative databases, so you can get a very rich number of covariates. And thinking about feasibility and cost, generally secondary data analyses are much less expensive than conducting your own trial. I mean, the data is there. Some of the data sets that I'm going to present are free. They're publicly accessible. Some you have to pay to access. But generally, it's the researcher's time that's involved in this, as opposed to some of the things that we talked about with the trial drug A versus drug B. However, they do have a number of limitations. They have the threats to internal validity because you're not controlling who got what type of exposure. So there are major threats to internal validity with secondary data analysis. The specificity of the questions asked is not, I mean, you didn't design, the data wasn't designed to answer your specific research question. So it's often where your particular study could look at drug A versus drug B. That's just might be one aspect of your data set that you could potentially answer, but it wasn't designed to specifically answer that. So getting at things like provider bias and some of that things that have changed over time, as was suggested, can be, that's the part of the researcher to disentangle those, which again is an issue related to internal validity. The data may be cross-sectional. So we talked about the last session about cross-sectional, the biases introduced with cross-sectional in terms of temporality. The exposure and the outcome are measured at the same time. So we're very limited in our causal inference, as opposed to trend data where we can actually follow people over time. So some of these data that are trend or longitudinal, that we can have a little bit more strength in our causal inference. But again, it all points to the need for a very strong conceptual model, which we talk about each week. So some of the secondary data sets that we're going to talk about today in terms of health surveys are PRAMS, the Pregnancy Risk Assessment Monitoring System, SLAITS, the State and Local Area Integrated Telephone Survey, which oversees both the National Survey or is the type of survey for the National Survey of Children's Health, as well as the National Survey of Children with Special Health Care Needs, the National Health Interview Survey, the Medical Expenditure Panel Survey, or MEPS, AdHealth, which is the National Longitudinal Study of Adolescent Health, and NHANES, which is the National Health Examination and Nutrition Survey. In terms of administrative databases, HCUP, or the Healthcare Cost and Use Project, has KID, which we'll talk about, the Pediatric Health Information System, or FIS, Medicaid data, vital statistics, and then there are a number of other linked databases that could include birth certificate and hospital discharge data, birth certificate and Medicaid data, early intervention, sometimes school system data, although there are a number of a number of obstacles related to not just HIPAA, but also with education data with FERPA, making those difficult to access. But one of the attributes of these survey designs, because they're nationally representative, is they include what we call design effects. And I wanted to spend just a moment talking about design effects. I wasn't going to, but I had an article that I recently got back from Pediatrics that was a revise and resubmit, and it had 3 reviewers. And I used a national data set, the early childhood longitudinal birth cohort, which I'm not going to talk about here because it doesn't have a whole lot of health outcomes. But if folks are interested in that, I'm happy to talk about it afterwards. But one of the reviewers said, I don't understand what you mean, why you included weights, or what you mean by weighted frequency in your table and complex survey design. And I thought, well, if it's not something that's common language, that I thought I might just go over it here today, because it's definitely a huge consideration for using these national data sets. Are folks familiar with design effects and weights when I say things like weights and being nationally representing national? Okay. So I will take a couple minutes, if you don't mind, just to go through that. So the designs that we talked about last week, or last session, assumed that we had a simple random sample. Okay, and certainly if we're talking about a data set that's going to represent our nationwide, and the nation's children or the nation's elderly, it is not possible to do a simple random sample, because essentially to do a simple random sample, what you then do is just randomly pick your group. Now certainly that is not at all, it is incredibly time consuming, it would be incredibly expensive and pretty much impossible to enumerate everybody in the United States. When you have a small clinic population, it's fairly easy to enumerate everybody and randomly pick people from your patient population where we're talking about a couple hundred people. It's not possible when you're talking about the nation. So instead, researchers need to come up with a way to sample people so that you ultimately have a random sample of people. And I will show you how they do that in just a moment. But I will also say that assuming that your data is from a random sample, so for any of the data that I'm going to present today, if you were to treat that as a simple random sample and forget about the complex survey design, you would come up with incorrect estimates. And we'll talk a little bit more about this next week when we talk about statistical analyses. So the take-home message is, if you're not comfortable with this, you should talk to a methodologist who understands weights and understands sampling frames and so forth, because many of the statistical software that we use, like SPSS and SAS, can do very simple procedures with survey weights and complex survey designs. But if you're going to do anything more complicated than a simple regression model, you need to move into other software. And not that we expect you to have the other software, but that's there are resources available, which I'll talk about at the end. And generally, the take-home message is to talk to somebody who knows about it, because you don't want to come up with incorrect estimates. Okay, so here's essentially what happens. So if we think about the United States, we want to have children's health, children in the United States. What happens is this is what we ultimately want to represent, but we can't randomly sample everybody. So then we use primary sampling units, or researchers, the National Center for Health Statistics uses primary sampling units. So if you're talking about, it could include things like a group of states, it could be New England, it could be this sort of mountain region here, it could be schools, the National Ad Health uses schools, depending on what you're sampling, your primary sampling unit might be geographically based, it might be schools, it might be clinic based, and so forth. And so this is what we mean by a primary sampling unit. So bringing back to the larger United States. And then within that, we form strata, which can be categorized by race, ethnicity, socioeconomic status, usually income. And within that, we sample people. So just to give you an example of what it might look like for race, ethnicity. And these are fictitious numbers right here. So let's just say within this primary sampling unit, the strata was race and ethnicity. And so this is the number of people were sampled. So about 76% of them were white non-Hispanic, a little less than 9% were black non-Hispanic, 11% were Hispanic, and 8% were other. We could stop there. The problem is that's not what's real, right? So we can look at census data to know what's actually real, what the number should be, okay? And so we know that the number should be around 60% for black non-Hispanic, just shy of 16%, and so forth. And so the way we get from this number to this number is through a survey weight. So that's why the weights are important, because the survey weight helps us move full circle back to representing everybody in the United States, okay? And so this can take a variety of looks depending on the data set that you use. So a couple of the data sets that I'm going to mention will use primary sampling units, but their strata will actually be at the state level. So the National Survey of Children's Health, for example, they basically kind of skip this primary sampling unit and move to a strata, which they have as a state. And so when you have that large level, that's such a large group in the strata, then they cluster people within that. And so they look at race, ethnicity, and SES, and so forth. So I just wanted to introduce that term cluster there, because oftentimes you'll see, you may not see PSU, you might see strata and cluster. But for things like the MAPS, the Medical Expenditure Panel Survey, they use a primary sampling unit and strata, and there's no cluster variable. Okay, but all of them use some kind of survey weight. And it's important to know generally how this process was done, because you can imagine if you had a primary sampling unit and then a strata by race, ethnicity, or gender, you would need a separate weight for each group, right? And that could be very cumbersome. So understanding how they come up with the survey weights, which oftentimes is a combination of SES, race, ethnicity, gender, and so forth, so that you have one weight that you can apply to your group, okay? It becomes a little bit more complicated when you have longitudinal data because you have, differential follow-up and so forth, so you might have different weights at different waves of the data. So again, not something you have to know everything about, but know what you don't know, right? And know that you should consult a methodologist to understand who can delve into, well, how was the sampling frame done, and what do I have to worry about with my survey weights? Questions about that? Does that make sense? Sort of. Getting some blank. Anything? Are there specific questions I can answer about it? Yes?
It just seems like if you have an outlier in one of the smaller groups and then it's weighted, then it can really skew your results.
Right. So the way they come up with the weight, that's a good point. So the way they come up with the weight is that it's inversely proportional to the number. So if you have a very, very small group, you're going to have an incredibly large weight. If you have enough, usually what happens is that's not usually a problem unless you're doing an analysis that really is teasing apart, is teasing these things apart. So if you're interested, for example, in state variation, let's say you're interested in immunization rates, or so if you're interested in state variation in immunization rates, and you have a model where you're looking at overall immunization rates, and you're parceling out sort of the role of the state and state policy around immunizations, and looking at individuals, then it can become a problem. But generally, if you have a large enough sample size, it's not usually a problem. I've never had it be a problem, except for when you're doing pretty complicated models. Yeah, but that's a good point. Yes?
So how much, if you're comparing two databases that might have similar information, how much do these different sampling strategies affect being able to compare those numbers? And I'll give an example.
Sure.
NAMSIS collects data on patients seen in the emergency department who receive drugs and radiographs for different pediatric respiratory conditions, say asthma.
Yep.
How many kids go out of the ER with prednisone, and how many of them got a chest X-ray? FIS collects similar data. And so there was a researcher who took those two data points and compared them to NAMSIS hospitals, which include community EDs, general emergency departments, and the FIS data, which is only freestanding pediatric hospitals. So how comparable is that data relative to the survey strategy? How do you account for that?
So that's a good question. So we're going to talk a little bit about that at the end, but some of it, so you bring up there are a few issues with it, with different databases. So to answer the question related to this part of it, in theory, if it's a nationally representative sample, it shouldn't matter in terms of its representativeness of the children. However, what is problematic is there's a lot of variability across hospitals in how everything that you mentioned in terms of who gets a chest X-ray, how the chest X-ray is read. I mean, you know this. So if you have variability in one institution, then you have a lot of variability across institutions on both sides of the data set, then that can be problematic. Because you need some way to account, and there's a way to account for it methodologically to account for that variability. So that's a reliability issue. The second is that you need to also consider risk adjustment, because the children who are seen by those different hospitals are very different from each other. And then if you're comparing, so they're different within that one data set, and then the FIS kids are also different within their own data set. So coming up with a way that you're going to risk adjust and risk adjust uniformly is a consideration. Not impossible, but it's difficult enough to do it in one database, but then you need to be consistent if you're to make sure you're comparing apples to apples. So that's really the problem, is that to compare apples to apples, you need to have the same exposure is the same for child A versus child B. And so that means that the way it's measured, the way it's administered, the way he presents to the ED is the same as child B. And so coming up with ways to adjust for that, that's really what the tricky part is. Not impossible, there's a lot of methodologic considerations that go into it that aren't necessarily in this part of it, because like I said, in theory, the data should be similar in terms of what it represents. There are some differences, though, I will say, in the data sets in terms, when you have to be really careful, is that some is individual level data, so it tracks individual children. You know, you're seen at the ED, you go back, you're readmitted, for example, or you're seen in the ED, you're discharged, you're readmitted to the hospital. In one data set, you are one child, and you're being tracked through the system. In other data sets, that's just encounter data. So we don't know necessarily that you're the same child. And we worry about things like that in KID because it's discharge, you know, it's administrative data where it's encounter data, not necessarily child data. So that's another thing when you're comparing two data sets you have to be really, really careful of, because you may have, you know, the sort of frequent flyers that is not, it's one subpopulation of kids that are being seen over and over and over again that are contributing to the encounters. So other, you know, just a lot of considerations that you have to just know your data set, know how it was sampled, know what it represents, and so forth. And, you know, you have to make assumptions along the way and sort of justify your assumptions. Other questions? Okay. Okay, so PRAMS. Are people familiar with PRAMS? Somewhat familiar with it? So PRAMS collects state-specific population data on maternal attitudes and experiences before, during, and shortly after pregnancy. So it's based on a random sample of birth certificate data each year. And it's about anywhere from 1,300 to 2,400 women, birth certificates. They do oversample high-risk women. So understanding who's oversampled in your survey is also really, really important to know. Often vulnerable populations are oversampled. It's not it's accounted for in, you know, all the things we just talked about in terms of the weight, so it doesn't change your estimates. But if you're interested in high-risk women and it's a rare, you know, a rare condition, let's just say, you might be able to find that information in a survey that's oversampled them. They're followed for about up to 4 months after their birth. So some of the things, if you're interested in barriers to and content of prenatal care, obstetric history, mom's use of alcohol and cigarettes during the pregnancy, physical abuse, contraceptive behaviors, economic status, maternal stress, very early infant development, supports and services that moms access, and so forth. This would be a really great data set. And for each of these, I've included the link to accessing the data. And I will say that, so you can get PRAMS data on almost, not every state, but a large number of states. And then states have also done state-specific modules. So it's possible that, for example, Colorado might have asked more specific questions about your area of interest. And so Colorado has done a lot of very specific modules. Alaska, there are a number of states that have really, you know, honed in on very specific topics. So it may be that you are really interested in Colorado, but South Carolina, for example, you know, has done a module on, you know, intimate partner violence or something like that. So you may use other state data. So the SLAITS data is, it provides in-depth state and local data. So it uses the same sampling frame as the National Immunization Survey, if you're familiar with that. The two modules that I'm going to talk about today are the National Survey of Children with Special Healthcare Needs and the National Survey of Children's Health. So in the National Survey of Children's Health, the purpose is to calculate national and state-specific estimates of the prevalence of physical, emotional, and behavioral indicators of U.S. children. It's a huge sample size, so almost 100,000 children in the United States, ages 0 to 17. It's cross-sectional, so it's a snapshot in time. So we're very limited in our causal inference. However, it has been done now three waves of it. So it's not the same kids in the waves, but it's very useful for trend data. So thinking about, you know, rising rates of autism, for example, changes in immunization, things that might have changed over the last decade or so. So it was done in 2003, 2007, and the 2011 data has just been released or is about to be released. It includes a number of physical and dental health measures, emotional and mental health, health insurance coverage, community and school activities, family health and activities, neighborhood safety and support, so thinking about neighborhood social capital and so forth. And this is where you access the data. It's free. It's very easy to access. They will make a very nice, clean data set for you. So if you're interested in thinking about, even though this might not be completely applicable to looking at national data like this as a sort of benchmark of your figures. For example, you mentioned that the abscess rate is slightly different than nationally. You may look, you would not be able to get abscess rate in National Survey of Children's Health, but for example, autism or immunization or some other, you can sort of use these national data as a benchmark to say, well, how are we doing as a program, or how are we doing diagnosing this, and so forth. National Survey of Children with Special Healthcare Needs. So similar sampling scheme as the previous, but it's focused on children with a special healthcare need. So they either have a diagnosed disability or functional limitation, they require more services or health, medical, educational services than their peers, they have a behavioral or developmental problem. It's about 850 children with special healthcare needs per state. It also has 5,000 controls that were sampled. So it's about a sample of 38,000 or so kids. It's again cross-sectional, but it's been done several years now. So the first was 2001, and it was repeated in 2005 and 6, and most recently, and these data are now out, the 2009 and 10 data. So it includes things like health and functional status of children with special healthcare needs, their access to care and care coordination, family-centered care, transition issues, thinking about transitioning to adulthood or transitioning from infants to toddlers to the school system, developmental screening. It's been used quite a bit to look at the rates of developmental screening, thinking about AAP guidelines and so forth. Certainly health insurance, access, and type of health insurance. It's very, very rich questions about the types of health insurance coverage that families have. New in 2005 and 6 and 9 and 10 has been the impact on families, so thinking about caregiver burden and so forth. They had in the most recent version, they had an ADD, ADHD module, so if that's something you're interested in, there's a wealth of, I shouldn't say a wealth of information, but a number of questions about ADHD, and certainly family income and composition. And again, these data are free, very easy to download. You get a nice clean data set in either SAS or Stata. And they're very, I will say for both of these surveys, the folks who run them are incredibly helpful. They're incredibly responsive if you have a question or you're not sure how to, they'll share code with you. It's there's a lot invested in these two data sets. The National Health Interview Survey, the purpose is to monitor the health of the United States population through the collection and analysis of a broad range of health topics. So it includes about 35,000 households and about 87,000 individuals. It's cross-sectional. It's done annually. It's been done annually since 1957. It's ingrained. There's policy around this. So this data set is not going away anytime soon. And it looks at a number of health issues, adult and pediatric. There are several. Every year they ask about child health topics and child health diagnoses and so forth. But over the last several years, there have been specific modules around things like asthma, ADHD, school days lost, time since last contact with a health provider, dental care, and so forth. So again, if these are things that you're interested in. Coming up with, looking back to see what some of these modules were. MEPS, the Medical Expenditure Panel Survey, collects data on specific health services that Americans use, how frequently they use them. A lot of health economists use these data because it's mostly around healthcare utilization, but a lot of clinicians are starting to use this because there's very rich information about diagnoses and types of services, medical services that patients are using. It's about 10,000 families or about 30,000 individuals per year. And the strength of this compared to the others is that it's a panel survey. So it follows people for 2 years and measures them at 5 different time points. So you can look at changes in health utilization. They have a number of demographic characteristics, of course, and health conditions are pretty robust in terms of thinking about health conditions and health status. Health insurance coverage. There are some special topics related to, again, ADHD and children with special health care needs. So thinking about how these families are using health services. And again, very easy to access. So the challenge here is because it's panel data is, linking those data together and understanding, how to do that to come up with one data set to analyze. Ad Health, if you're interested in adolescents, it includes 21,000 adolescents between the grades 7 through 12 from 80 schools. So here, this is the primary sampling unit here is the school, and then they randomly sample students within schools. It's a longitudinal study where they followed kids up 1994, 96, 2001 and 2, and most recently in 2007 and 8. So, you know, a lot of it is school data, but, you know, people are getting very interested in network and network analysis related to health, so who your peers are and how that affects your health. So, and they've also included, in the most recent wave of it, they've started collecting biological data. So that might be of more interest to this group. And here's how you access it, the site here. All right, I'm going to skip over NHANES just so we can get to some of the administrative databases. So KID is a database of hospital inpatient stays for children to identify, track, and analyze national trends in healthcare utilization. So again, similar to the MAPS, but a larger sample size and focused only on children. So it's 3 million hospital discharges, which they say is about 85% of the total that happen in the United States. It's repeat cross-sectional, and it's done every 3 years. And the most recent is 4,000 hospitals from 44 states with inpatient stays for kids less than 20. So, you know, pretty representative of the United States. It includes primary and secondary diagnoses, procedures, admission and discharge status, certainly patient demographics, expected payment source, total charges, length of stay. Often length of stay is for folks researchers who use the KID, length of stay is one of their main outcomes. Hospital characteristics, so it'll let you look at if it's a academic hospital versus not, urban and rural. It's not, you know, you're limited, somewhat limited in your hospital classification, which can be frustrating to researchers, but you know, there are probably 4 or so groups that you can kind of cross-tab and figure out a matrix for thinking about different types of hospitals. And like I mentioned, it's managed by HCUP and AHRQ, the Agency for Healthcare Quality and Healthcare Research and Quality. And here's the data set. FIS, we talked a little bit about FIS, is a detailed comparative database that gives participating hospitals and clinicians the ability to assess and improve resources for patient care, can lead to quality improvement. It's 41 not-for-profit freestanding U.S. pediatric hospitals in the United States. It's longitudinal, it's done annually. Each year they contribute to the data. It includes patient-level discharge data, demographics, diagnoses, and so forth, utilization information in terms of pharmaceuticals, physician subspecialties. A little more challenging to access the data compared to the other ones. I would say of the ones I presented so far, this is probably the most challenging. But here's the website where you can register to access the data. Medicaid data. The purpose is for surveillance, quality improvement, and tracking of patients enrolled in Medicaid. It provides person-level data from state Medicaid administrative databases. It's available for all 50 states and the District of Columbia since 1999. The measures include things like eligibility for Medicaid, service utilization and payments, and you can look at type of service, place of service, ICD-9 codes, CPT codes, and so forth. And here's how you access the data. All right, I'm going to skip over this to go through some of, because I want to leave a couple minutes for questions. We're running out of time. But so some considerations for the health surveys that I mentioned. So things like the National Survey of Children's Health, National Survey of Children with Special Health Care Needs. As I mentioned before, they're cross-sectional, so there's no temporality. We have to understand the design effects and the weights and when to include the weights and so forth. Also, with these national data sets, there's usually a very large number of missing data, particularly related to income, upwards of 20%. So for those 2 data sets that I mentioned, there's a multiply imputed income file for data. So again, not something you would need to know how to analyze, but know that you need to consult a methodologist around how you would use that multiply imputed data file and incorporate it, because the problem is if you ignore people that have missing data, you're losing 20% of your sample. And we know that people who don't report their income are different than those who do. So understanding how to get around that that just methodologic consideration. And again, we talked about this before in terms of sample size and power. When you have 97,000 children, any crosstab is going to be statistically significant. So coming up with other methods that you're going to think about effect estimates and not just using a p-value or a confidence interval, and thinking about how you might use other alternative measures to look at effect sizes. And we talked about these a little bit in terms of the administrative databases. So risk adjustment, certainly, when you're talking about 41 different hospitals, those hospitals serve very different populations of kids. And so how you're going to adjust, risk adjust across your different hospitals, varying reliability of measures across hospitals and areas, and not having a good sense of how reliable your measures are. I mean, you may have a sense from your own particular institution, and you may have colleagues at others, but trying to get a handle on how much the reliability varies across institution. Often, these data are retrospective observational data, which we talked about in our first example about the drawbacks of that, whether it be time or things that aren't measured and so forth. Again, 1 million observations, everything is going to be statistically significant. So doing a regular regression and coming up with a p-value is just not appropriate. You do worry about confidentiality. Even with 1 million observations, if you're talking about a rare condition in a rural hospital in Colorado, you're getting into patient confidentiality issues, and you might have limited, sparse sample sizes and so forth. So understanding those considerations. And I will also say accessing and cleaning the data is incredibly difficult, and I didn't give justice to the time that's involved for all of these administrative databases. The health surveys will come to you in a nice, clean data set. Medicaid is not. Phys is not. KID is not. It is very difficult to decipher even the CPT codes, place of service, type of service. Often, what we're working on right now for the Medicaid data is actually coming up with a roadmap for other research, for us to use, and we're hopefully going to publish it as a roadmap, because there's really not much out there in terms of how you come up with the classification systems for even well-child visits versus specialty visits versus therapy services and so forth. So knowing that ahead of time, and again, it's your time. This is not what you gain from this is a ton of information that you're not conducting the study yourself, but it's time that you need to put in to be able to decipher to decipher your data and to make sense of it, to actually classify the exposure and the outcome in the patients. And it sounds very simple, but it's something we're currently struggling with. So I can share with you that it can be really, really challenging, and questions that you think you should be able to answer, as simple as length of stay for different procedures, understanding who did the procedure, whether it was a surgeon or somebody else, or when it happened, where it happened, is not always very cleanly recorded. And I just wanted to end with some resources for you. So we at CORE are certainly available to help with some questions around secondary data analysis. The CCTSI here on campus has an informatics research team that within it has a secondary database library and analysis center. So that's another resource for you. From what I understand, you don't necessarily have to be on a funded project for them to, or a project associated with the CCTSI, that they have resources available to help you with, answer many of the questions that we talked about today in terms of the methodologic considerations. They, specialize in the ARC databases, so, MEPS and KID and so forth. They have a lot of expertise in that. So I think we have maybe, a minute or something for not even for questions, but I'm happy to stay after if folks have questions. And Allie apologizes for not being able to be here. She's in the middle of a move, so she's not able to be here. But next week we'll talk about statistical analyses. So, yeah.
Give like an example of a question that was used that was use these databases to get an answer. One of these databases.
Yeah, so KID, people look at, so the example that we brought up before about the open versus laparoscopic procedure, comparing surgical procedures. So David Fox just published looking at, G-tube placement. So he was thinking about G-tube placement, and so a lot of other surgical procedures, and sort of the outcomes related to that. So length of stay, related to post-surgical procedures is what I've seen mostly with KID. We have another colleague who looked at children with Down syndrome. She was looking at the effect of elevation on obstructive sleep apnea in kids with Down syndrome. And so it's she had national data, so she could look at sort of C-level admissions related to sleep apnea and compared it to pneumonia and looked if there was a differential effect of elevation on obstructive sleep apnea in kids with Down syndrome. Yeah, I mean, the Medicaid analyses, we're looking at a whole host of things related to therapy services, pharmaceutical use, child visits.
So some
Yeah.
specialist questions are often surgical in nature.
From what I've seen, yeah. I mean, it doesn't have to be. I mean, I should also say I'm working with a group of pediatric surgeons, so that's part of it, that they tend to ask surgical questions. So I don't know how, right, exactly. So I would say, yeah, the surgical questions, and then Kristen's around Down syndrome and obstructive sleep apnea. Yeah, I mean, you certainly could use, I mean, it has a wealth of information that's not just surgical related, but if you do yeah, it's mostly, from what I've seen, just even outside of Colorado, it seems like most people have used it for surgical procedures and outcomes related to surgical procedures. Yeah. Yeah.
So I'm curious about this Medicaid information because of a question I've been thinking about. So who would we contact to kind of get help about, could this database help us answer this question? Is there someone specific in the CDLAC or?
You could, or you could, I mean, is it children's Medicaid, right? Children's Medicaid, yeah, I mean, you could ask me. I'm using it, so I could probably tell you if it's in there. Or, you could ask, there's a whole group of us at CORE, not the surgeons, but we have a children with special health care needs group that's using we have Medicaid data for 4 states over 3 years. So we have it from, because the trouble is different states report things differently, and so I would, if it's something that can be answered with one state's data, I would say that's going to be a lot easier for you. I mean, it's rich to be able to combine states, but it's also very challenging.
Do they have the information per patient? Because you said it was person, so they have the Medicaid number.
Yep.
Okay.
Yep. So you can track, whether inpatient hospitalization, because it's utilization that's covered. So it's billing data. So they'll cover, outpatient, inpatient, other home services. Anything that Medicaid pays for will be included in the data set. Yep. And obviously all their, ICD-9 codes, diagnostic codes, and yeah. So if you click on the website, or if you want to come and talk to us, if it's a Colorado-specific question, yeah. Thanks.